Now it's 9 o'clock. I think we should all start with the meeting. I will request everyone to stand for Doctor's prayer, please.
सर्वे भवन्तु सुखिनः
सर्वे भवन्तु सुखिनः
सर्वे सन्तु निरामया
सर्वे सन्तु निरामया
सर्वे भद्राणि पश्यन्तु मा कश्चित् दुर्भाग् भवेत् न त्वहं कामये राज्यं न स्वर्गं न पुनर्भवं कामये दुःखताप्तानां प्राणिनाम् आर्तिनाशनम्।
कलकत्ता इंसिडेंट के बारे में बात हो रही है जो आज गवर्नमेंटल कॉलेज में हुआ है उसके बारे में, और उसी के रिलेशन में अभी हम लोग बस 1 मिनट या 2 मिनट का कंडोलेंस, 1 मिनट प्लीज खड़े होके एक बार 2 मिनट की कंडोलेंस कर लेते हैं। Thank you. Now I would like to invite Dr. P.C. Shahi sir to take the charge for scientific session.
So, good morning everyone. Welcome to today's CME on approach to peripartum cardiomyopathy. We are thrilled to have you here as we dive into this important and often challenging topic. As a general practitioner, it's very crucial to stay informed about conditions like peripartum cardiomyopathy, which is, although rare, but can significantly impact the maternal health. Today we will be exploring the latest research, clinical practices and treatment strategies to better understand the management of peripartum cardiomyopathy, and today we have a very excellent speaker who will share his expertise and insight. Thank you for joining us, and I hope you find today's session both informative and enriching. And with this, I would like to welcome our speaker, Dr. Gajendra Gupta. He is MBBS, MD and DM in cardiology, and presently is practicing as a consultant interventional cardiologist at Ernst Heart Clinic at Gorakhnath and Rana Hospital as a consultant. So please join us to welcome our speaker, Dr. Gajendra.
Thank you, sir, and thank you giving me an opportunity to present this topic here. And let me introduce myself. I am Dr. Gajendra Gupta. I did my MBBS from GMC Raipur, then MD from GMC Bhopal, then I did my cardiology from Yashoda Hospital, Sikandrabad, and I was associate consultant for around 1 year there. And after that I was start practicing here with Rana Hospital as an intervention cardiologist, and I have one clinic in Gorakhnath in front of Anandlok Hospital, Ans Heart and Maternity Clinic. So today our topic of discussion is peripartum cardiomyopathy. So in registry of Indian registry or incidence is around 1 in 1500, but I think it's more than that. Our registry system is not up to date, especially our Indian data is. So in 1.5 years of my career in Gorakhpur, I have seen around 30 cases of peripartum cardiomyopathy, and it's around completely reversible. Almost 99% of the patients are completely reversible within 3 months, 3 to 6 months. Completely like from severe LV dysfunction to normal LV dysfunction, from EF 30% to normal 50 to 60%. So highest incidence is in African countries. In African, specifically Haiti. Haiti is one small country. There its incidence is around 1 in 300. Every 1 in 300 delivery there is a risk of the peripartum cardiomyopathy. So objectives of our topic is like define the what is peripartum cardiomyopathy and identify those who are at the risk, and understand the management of the heart failure during pregnancy, lactation, and after that, and role of bromocriptine and anticoagulation, and evaluate the risk of subsequent pregnancy, like after that we have to plan the pregnancy or not. So what is peripartum cardiomyopathy? So this is heart failure. This is the variant of the heart failure with reduced ejection fraction. EF should be less than 45%, not diastolic. This is only systolic dysfunction. So this is heart failure during the end of the pregnancy. So highest incidence what we used to see is end of the month, like 9 month, and most of the cases are diagnosed after the pregnancy, at the end of the pregnancy, after the delivery, in the first month of the pregnancy, first month after the delivery. So this is the diagnosis of the exclusion. We have to exclude all other possibilities, and the fate of the disease is it may recover completely or may rapidly progressive symptoms if we will not diagnose in right time. If patient is not get any proper treatment, that it may progressive, and there is the risk of the death also. So in all maternal death, around 28% of the cases are due to peripartum cardiomyopathy, and other causes are stroke, hypertension, arrhythmia, and coronary disease. So usual traditional time of the diagnosis is at the last month of the pregnancy, and more than 90% cases are diagnosed at the first month of the pregnancy. Around 75% cases are diagnosed at the first month of the pregnancy. So definition is typically at the end of the pregnancy or after delivery till 5 months of the pregnancy. If there is heart failure with reduced ejection fraction, so that is under the peripartum cardiomyopathy. So around 25 to 30% cases are mixed diagnosed, like asthma, pneumonia, influenza, common cold, or fluids in lungs, and any gallbladder disease, panic attack, stress, or postpartum depression. So around 25 to 30 cases are misdiagnosed. So risk factors, this is more commonly seen in African patients, African American, and if there is preeclampsia is also a risk factor, and if there is pre-existent hypertension, older maternal age, multiple gestation, multiparity, anemia, asthma, and autoimmune disease, hyperthyroidism, obesity, or diabetes, or any mood disorders. So we can see in all deliveries there is a risk of preeclampsia in E graph, and there is second one is F graph. If there is a preeclampsia, so incidence is much more higher as compared to the normal pregnancy. So preeclampsia is risk factor for the peripartum cardiomyopathy. Preeclampsia is there and patient is complaining of shortness of breath or breathing in the difficulty, so we should think for the peripartum cardiomyopathy, and we should evaluate for that. So pathogenesis is there is a angiogenic imbalance. So there is one protein that is called prolactin processing. Prolactin is cleaved in 16 kilodalton protein, that is pro-apoptotic, and that leads to endothelial dysfunction and cardiomyocyte ischemia and damage. This is one hypothesis of the this pathogenesis, and second one is immune response to the fetal cell, that is one fetal protein that is called soluble fatty liquid 1, and other risk factors are genetics, that one protein that is called titin, and other risk factors are viral myocarditis. So this is pathogenesis. This is prolactin. This is cleaved in the 16 kilodalton, that is this leads to endothelial dysfunction and apoptosis, cardiomyocyte ischemia, and this all leads to cardiomyopathy. And second one is placenta. In placenta one protein is secreted, that is soluble fatty liver 1, that is also inhibit the growth factors, and which is also lead to apoptosis process. So this is same. So clinical presentation is like a normal heart failure, like most common symptom is dyspnea. Other symptoms are cough, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, non-specific fatigue, discomfort, abdominal pain, and there may be possibility of the systemic or pulmonary embolism if there is a ejection fraction is less, and if there is any LV thrombus. So it can lead to any embolic or pulmonary emboli can be done. And this is more common seen in peripartum cardiomyopathy as compared to the other cardiomyopathies. And risk is exacerbated by the hypercoagulable state of the pregnancy, because pregnancy is already hypercoagulable state, and if there is a peripartum cardiomyopathy, so risk of the pulmonary embolism or systemic embolism is more. So differential diagnosis of the peripartum cardiomyopathy is if there is pre-existing dilated cardiomyopathy and which is unmasked and directly we have seen in the pregnancy, and other pulmonary embolism or pre-existing other congenital heart disease or any rheumatic heart disease or hypertensive heart disease or rarely any coronary artery disease, that is myocardial ischemia or HIV or AIDS cardiomyopathy. So these are the differential diagnosis. So peripartum cardiomyopathy is diagnosis of the exclusion. So differential diagnosis we have to be in mind, like pre-existing dilated cardiomyopathy, valvular heart disease, and congenital and pulmonary embolism. So investigations we can do is ECG. ECG generally will see it's normal, or any sinus tachycardia may be seen, or sometimes there may be RBBB pattern or any stent pattern. If there is hypertension is there, so we can see. And BNP or anti-pro-BNP level may be raised during the peripartum cardiomyopathy. In chest X-ray, if dilated cardiomyopathy is associated, so we can see any associated cardiomegaly or pulmonary hypertension, or in cardiac imaging, most important is the 2D echo. So best thing to do 2D echo. So we can exclude all other things. If there is a valvular heart disease, pre-existing any dilated cardiomyopathy or any other thing, we can rule out with the 2D echo. So most important, we should go for the 2D echo. So management is similar to normal heart failure, but there is the difference in management in during the pregnancy, after pregnancy, and during the lactation. So our goal is during the management to optimize the hemodynamics, symptomatic relief, and improve long-term outcome. So in pregnancy, certain drugs are restricted, like AC and ARB we cannot give, that is contraindicated, that can cause renal agenesis or other renal inhibition. And beta 1 selective drugs are preferred as compared to the beta 2 in beta blockers. In beta 1, like metoprolol or atenolol, esmolol we can give, that is cardioselective beta 1 selective beta blocker. So while pregnancy we can give diuretics, beta blocker, beta 1 selective beta blocker, hydralazine, nitrates, digoxin, and avoid nitroprusside if possible, because there is risk of the cyanide poisoning. So we should avoid nitroprusside. And after delivery, standard heart failure treatment like diuretics, AC, ARB. Nowadays we are using ARNI, that is combination of the sacubitril and valsartan, and beta blocker, aldosterone antagonist, and SGLT2 inhibitor, and MRA. So there is a SGLT2 inhibitor, ivabradine, and MRA. There is no studies during the lactation, so we don't know they are secreted in milk or not. So we should avoid SGLT2 inhibitor, MRA, and ivabradine for rate control. So these are all medicine which we can use in heart failure, after the heart failure in peripartum cardiomyopathy. Beta blocker, AC inhibitor, ARB, MRA, and ivabradine we should avoid. So we should use all the medicine step by step, and we should first we should discontinue MRA. After recovering the LV function, first we should delete MRA. Then after deleting MRA, we should continue all the medicine till 6 months. Beta blocker, ARNI, AC, ARB, we should continue till 6 months after recovery of full LV function. After 6 months, we should delete AC, ARB, or if you are using ARNI. Then after 6 months, we can discontinue beta blocker, and after confirming with echo and all other things. So last we should delete beta blocker, and first we should avoid MRA. So bromocriptine nowadays we are using bromocriptine. So there are some limited research for the bromocriptine. So this is in 20 patients, this is data is done. So if you we are using bromocriptine and standard drug of therapy of the heart failure, so death risk is very less in a bromocriptine group, and combined end point is also very less in bromocriptine end group. So we have seen that there is role of the bromocriptine in pathogenesis. So this is some evidence, and some limited research is only done in bromocriptine with heart failure, but there is a positive. So with use of bromocriptine, there is risk of the thromboembolic complication like stroke, LV thrombus, MI, seizures. So whenever we are using bromocriptine, we should use like warfarin or Novex to prevent that stroke or any thromboembolic risk, because his pregnancy is already hypercoagulable state, and if we are using bromocriptine, we should always use warfarin or other Novex to prevent stroke risk or thromboembolic risk. So in so these drugs we can use bromocriptine. So dose of bromocriptine is 2.5 mg daily, for we can use up to 2 weeks. Here it is written 7 days, but we can use up to 2 weeks 2.5 mg BD. Then after 2.5 mg OD up to 4 to 6 weeks. So total 8 weeks we can give, initially BD, then after OD. And other heart failure drugs like beta blocker, AC inhibitor, and anticoagulation. If there is a risk, there is a AFA, atrial fibrillation is there. If there is LV thrombus and EF is very suppressed, EF is less than 30%, and if we are using bromocriptine, so we should give anticoagulation. And relaxing like vasodilators if BP is more than 110, and diuretics for symptomatic relief. So anticoagulation, as I told, there is limited data. So if there is therapeutic indications are if there is any intracardiac thrombus and systemic embolism or atrial fibrillation is there, then we have to give. If there is a low EF and other risk factor, or if we are using bromocriptine, then we should give anticoagulation. So warfarin is safe in with breastfeeding. So warfarin, one research is there. So one mother who are using warfarin, so accidentally she took 25 milligram of the warfarin for 2 to 3 days. After that they have checked in the baby's blood, so there is negligible amount of the warfarin. So warfarin is safe while breastfeeding, and heparin is also safe, heparin, enoxaparin, because these are larger molecule, so that cannot excited in the breast milk. And in a newer anticoagulant like dabigatran and apixaban or rivaroxaban, so dabigatran is detectable in very negligible amount, like 1 lakh time below the concentration, that will have significant effect of the coagulation effect. Whatever we have seen in a mother's blood concentration, so 1 lakh time lower, that can be seen in a breast milk. So it is also safe. We can give dabigatran. So dose of the dabigatran is 110 to 150 mg. And next rivaroxaban and apixaban, this can be also seen in lower concentration in breast milk. So better is to give dabigatran if we are using Novex, and safest is warfarin. So predictor of the recovery in for future pregnancy, LV diastolic dimension. If diastolic dimension is less than 5.5 to 6 centimeter, so chances of the recovery is more, and EF is more than 30 to 35%, then also recovery is better. And fractional shortening of the LV is more than 20%, and there is a lack of troponin level, lower level of the BNP, and if there is absence of LV thrombus and absence of breastfeeding and non-African American ethnicity, there is recovery is better in this population group. So there is some condition where pregnancy should be avoided, like pulmonary hypertension of the any cause. If any cause, if there is pulmonary hypertension, we should pregnancy is contraindicated. So one of that is peripartum, previous peripartum cardiomyopathy with any residual impairment of the left ventricular function. We should avoid pregnancy. In a future pregnancy is if LV function is not improved, so we should avoid the peripartum cardiomyopathy. There is a risk of the recurrence. So risk predictor of the LV function before pregnancy. So if there is a relapse heart failure, if there is LV is not recovered, so there is risk of the relapse is more. If there is 14%, if there is a risk of persistent LV systolic dysfunction, or there is 13% of the risk of the premature delivery, and 0% risk of the maternal death. If there is recovered LV function, if LV function is recovered fully more than 50%, so in next pregnancy, so there is a very low risk of the maternal death and very less risk of the premature delivery. If LV function is persistent and not recovered, it less than 50%, so there is high risk of the relapse of the peripartum cardiomyopathy in future pregnancy, and risk of the maternal death is around 18%. So we should avoid if LV function is not recovered in future pregnancy. So close monitoring during the pregnancy is required. If before the conception, end of the first trimester, end of the second, in next pregnancy, if there is a peripartum cardiomyopathy in next pregnancy, we should monitor. Before conception, end of the first trimester, end of the second trimester, and first month prior to the delivery, and after delivery prior to the discharge, and first month after the delivery. So breastfeeding, as we have been discussed, so better to avoid breastfeeding. So because if we are using bromocriptine, that is also lactation will be suppressed. So in some ESC group, they are saying better to avoid breastfeeding. In some data, they are saying to continue the breastfeeding. So take home points for today's postpartum cardiomyopathy defined as LV ejection fraction less than 45%. Its diagnosis of the exclusion, and BNP is useful, and medications can be used during pregnancy are diuretics, beta blockers, isoniazid, hydrolysin, and during the breastfeeding diuretics, beta blocker, enalaprine and spironolactone, and consider anticoagulation if there is increased risk of the LV thrombus, depressed LV function, and if there is atrial fibrillation, especially with hypertension and post-operative. And if there is a risk of the subsequent pregnancy are complex, depend on the ejection fraction. If EF is not fully recovered, so relapse rate is very high.
Thank you, Gajendra, for such an informative session. I think it was very, very practical, and you have given in a very brief manner. Thank you so much. Now I request Dr. R.K. Pandey sir to please join for the quiz session.
So which signs and symptoms develops toward the end of the pregnancy and require prompt evaluation for the peripartum cardiomyopathy?
Just raise your hand.
Palpitation, abdominal pain, face or hand edema, anorexia.
आप बताइए आंसर शायद
नहीं आंसर जो सही हो उसको आपको सेलेक्ट करना है.
मैं बताता हूँ. So answer is palpitations. So next question is, which diagnostic imaging test should be performed in patients who are suspected of having peripartum cardiomyopathy? CT, PET, echo or echo?
Dr. Imran? Okay. Chalo, ठीक है. Next. Which is the most accurate about diagnostic testing in peripartum cardiomyopathy? Elevated creatinine phosphokinase is diagnostic. Second is elevated levels of BNP or serum creatinine level more than 0.8 or clinical use of tropi is not entirely clear in patient with peripartum. Which is most accurate?
D is cancer. D.
So your answer is B. So once again I just wish कि आप फिर से एक बार इसको फिर से पढ़ें. Which is most accurate about diagnostic testing in peripartum cardiomyopathy? Clinical use of tropi is not entirely clear in patient with peripartum cardiomyopathy. It was a tough question and great answer by Dr. Omkar. Please give him a huge round of applause. बहुत बढ़िया. Which is most accurate about diagnosing peripartum cardiomyopathy? It's a diagnosis of exclusion. Nuclear stress testing is possible during the first trimester. Endomyocardial biopsy can provide additional data. Thrombocytopenia is usually present in peripartum cardiomyopathy. Dr. Sanjeev? So peripartum cardiomyopathy is a diagnosis of exclusion. So that's the right answer. I think that's all. There must be some questions from the audience. Please
Lobetlol. Yes, sir. So lobetlol is not beta 1 selective. That is non-selective.
If you look at the management of heart failure in any patient, the most common beta blocker used are carvedilol and metoprolol. So these are the two drugs recommended also for this peripartum cardiomyopathy. Labetalol is mostly used for the hypertensive emergencies in pregnancy, not for this heart failure.
डाटा की बात है, 2 पॉइंट है कि प्रेगनेंसी में यदि हो रहा है 9th मंथ में तो लेबेटोलॉल को यूज कर सकते हैं क्योंकि डाटा नहीं है, लेकिन जब आप डिलीवरी हो गई उसके बाद
Carvedilol and metoprolol is both. Definitely, that is the condition.
But we can use metoprolol and carvedilol in last month of the pregnancy also. In last month of pregnancy we can use. Yes, sir.
पेशेंट को लास्ट मंथ में आता है, पेशेंट या पेरीपार्टम पीरियड में आता है, आपने एक जीडी दिया था कि अनमास्किंग ऑफ डीसीएम, पेशेंट का ऑलरेडी डीसीएम में पड़ा हुआ है और प्रेगनेंसी के दौरान या बाद अनमास्किंग हो गई, उसको कैसे डिफरेंशिएट करेंगे कि ये पेरीपार्टम है कि पेशेंट को ऑलरेडी डीसीएम है? कोई जांच नहीं है, पेशेंट इमरजेंसी में आया है आपके पास ईको मशीन भी है और सब कुछ है आपके पास, कैसे डिफरेंशिएट करेंगे कि दिस इज पेरीपार्टम
pre-existing. So mostly in DCM LV will be dilated, sir, and in peripartum cardiomyopathy LV will be not that much dilated. EF तो दोनों में reduce होगा, EF दोनों में reduce होगा, but dimension of the LV size in most of the cases of the DCM LV will be dilated and thin out.
What I feel, if the patient is symptomatic, if she is not symptomatic earlier and during pregnancy in last trimester after 9 months of period, if she became symptomatic, then it should be considered as a peripartum cardiomyopathy, right?
And we had a patient who had undergone cesarean section, and we had transfused 2 NS during the operation. After that, patient was absolutely normal. On the day of discharge, she suddenly developed palpitations, breathlessness, and everything without any chest pain. Pedal edema is a normal finding in all the pregnancy cases. So first of all, the first thing that came to our mind was whether she had peripartum cardiomyopathy or not. So echo was done by Dr. Bishisari, and the report was that she had moderate MR with normal valves,
yes,
and moderate pulmonary hypertension. So I put her on Ditor plus RPD along with cilnidipine, just to negate some effects of moderate hypertension, pulmonary hypertension. With that, she is fine, and she is gone home. Once she comes back, then probably I put her on endothelin antagonist.
Yeah, definitely. So there are multiple etiologies which can lead to dyspnea in pregnancy. So this was the valvular case. So one should rule out the echo is the most common easy modality which is really available.
If we are using bromocriptine, so till the duration of the bromocriptine we should use the 2 weeks for the BD, and after that we can further go for 4 to 6 weeks. So we should use anticoagulation, and if LV is not recovered, ejection fraction is less than 30%, so we should continue. After that we should discontinue.
एक क्वेश्चन मेरा सर, जैसे यदि टोटल को जब समराइज करें तो क्या हम ये कह सकते हैं कि एक्यूट एलवीएफ का मैनेजमेंट के अलावा कोई स्पेशल मैनेजमेंट हम नहीं कर रहे हैं? ये है क्या? नंबर 2 कि यदि हम इटियोलॉजी में प्रोलैक्टिन को इन्वॉल्व कर रहे हैं तो क्यों हम एंटीप्रोलेक्टिन ड्रग नहीं देने की बात कर रहे हैं? कोई डाटा ऐसा बीच में डाटा आया हुआ था जिसमें कहा गया था कि आपको एंटीप्रोलेक्टिन ड्रग देना है, जैसे ब्रोमोक्रेटिन या एनीपरगोलाइड यूज होती है कि आपको सप्रेस करना है मिल्क को, क्योंकि यदि पूरी इटियोलॉजी एक लाइन में बात करें तो प्रोलैक्टिन को ही सब बनाया गया कि इसी ने यही कर रहा है। तो हम इस पे ब्लॉकेज के बारे में क्या डाटा है, और यदि नहीं तो फिर केवल एक तरह से हार्ट फेलियर का मैनेजमेंट हम सिर्फ इसमें कर रहे हैं और पेशेंट को कह रहे हैं कि वेट करिए आप? दैट्स ऑल।
So there is very limited data with bromocriptine. Like I have seen around 3 to 4 research only is there, but all research are positive for the bromocriptine.
Side effects are more.
So
एक
in
क्वेश्चन
peripartum cardiomyopathy, the difference only is this is a thrombogenic malady, and with bromocriptine the thrombus formation chances are very high.
Very high.
So without atrial fibrillation, you can consider anticoagulation in these patients also.
Even giving diuretics will increase the risk of thrombus formation.
Yeah, definitely there are.
The volume.
So that is the one difference which you should consider.
एंटीकोगुलेशन देना है।
Anticoagulation तो आपको consider करना है, and duration can be depending on the echo findings, how the LV is moving, कैसे proceed कर रहा है, उसके हिसाब से आप duration determine कर सकते हैं. And the thing is कि most of the time this is I think it's a very benign entity जिसमें हम लोग complete reversal देखते हैं, and medicines मतलब आपको बस यही प्रिवेंशन लेनी है कि सेकंड प्रेगनेंसी के लिए पेशेंट को थोड़ा सा काउंसिल करना है कि दैट इज रिस्की, और फिर से दोबारा अगर रिकरेंस होता है तो वो थोड़ा सा और ज़्यादा सीवियर कंडीशन में होता है।
इसमें आपने हाइपरथायरॉयडिज्म बोला है, जबकि हाइपोथायरॉयडिज्म में ज़्यादा आप देखिए कार्डियोमायोपैथीज होती हैं।
हाइपरथायरॉयडिज्म इज अ रिस्क फैक्टर फॉर पेरिपार्टम, यू आर राइट।
Hypothyroidism, subclinical hypothyroidism can give rise to all these things.
Mostly hypothyroidism में we are seeing the pericardial effusion presentation होता है।
The basic culprit is prolactin. इसमें
Sir, actually etiology is not known. There are
known.
inflammation, autoimmune, and this prolactin is considered to be the main etiologic factor, but nobody exactly knows.
Clear.
मेरा
What?
एक क्वेश्चन इसमें ये है कि जो बाकी हाइपरप्रोलैक्टिनिमिया वाले केसेस हैं उसमें भी क्या ऐसा मिला है कभी कार्डियोमायोपैथी?
क्यों नहीं होता?
Right, sir.
उसमें प्रोलैक्टिन पूरे बॉडी पर इफेक्ट दिखता है, इंक्रीज वेट एंड लॉट ऑफ थिंग्स आर देयर। उसमें कोई स्टडी हुई है इस तरह का, कोई कार्डियोमायोपैथी केस आया?
No idea.
Sir, I think other risk factor we should consider, like if there is a hypertension is there, multiple pregnancy, so if age is more, so we should consider all the things. और आप जो बात कर रहे हैं उसमें केवल प्रोलैक्टिन की बात कर रहे हैं, सो आई थिंक पूरा कॉम्बाइन करके इसमें रिस्क फैक्टर ज़्यादा होता है। यस, हाँ।
प्रोलैक्टिन जिसको हम हीरो ऑफ ब्रेस्ट फीडिंग कह सकते हैं, उसको हम इतनी आसानी से विलेन के रूप में रोल में ले आए। प्रोबेबली आई थिंक देयर सम रिसर्च, क्योंकि ब्रेस्ट फीडिंग ऑफ प्रोलैक्टिन वी कैन टॉक ऑफ इट लाइक अ बैकबोन ऑफ ऑल द ह्यूमन मैनकाइंड, आई कैन से। तो आप शायद उसके बारे में ज़्यादा बात करके हम एक गलत संदेश अपने मरीजों में या डॉक्टर लगा है। मैं सोच रहा था कि ये क्या, क्योंकि जिसको हम ब्रेस्ट फीडिंग का प्रमोशन अभी 1 से 7 अगस्त तक किए हैं, जो ग्लोबली किया जाता है,
The role is controversial. But one can consider depending on the
हाँ, वो
severity
आगे
of the
तुमको
condition.
बैठा के रखना है, इमरजेंसी केस में क्या 10 मिनट में आ रहे हैं बोल देना।
40% से less हो गया है।
हाई है, कंट्रोवर्शियल पॉइंट है।
Controversial.
Yes, sir. Yes, sir.
Controversial.
हाँ।
True, very true, sir. So गायनकोलॉजिस्ट का भी मैं एक बार एक्सपीरियंस जानना चाहूँगा कि आप लोगों का कितना फ्रीक्वेंसी है, मतलब ऐसे पेशेंट्स के देखने का।
I have seen 3 or 4 patients till now.
Till now,
3 or 4.
okay.
It's a long span.
हाँ
But
मैम,
it is very scary. We get very scared.
हाँ
4 patients का है मेरे पास। तो
और
mortality 50% है इसमें। मतलब ये उस समय की बात है जब वहाँ पे अपने यहाँ एको वगैरह गोरखपुर में होना पॉसिबल नहीं था।
राइट राइट।
तो हम लोग को मतलब वही फिजिशियन से जो डायग्नोसिस बनती थी उसके बाद वो जो भी ट्रीटमेंट कर रहे हैं कार्डियक फेलियर के हिसाब से कई बार नहीं मैनेज होता था। तो हार्ट सेंटर पे जाने के बाद भी हम लोग इतना फॉलो कर पाते थे।
मॉर्टेलिटी आपने ज़्यादा देखा है।
50% mortality. No, but then it might not be only peripartum. It could be pre-existing dilated cardiomyopathy.
Yes.
Yes.
I mean, you're not sure.
I think most lethal is valvular. If there is rheumatic heart disease, severe mitral stenosis with severe PS, severe aortic stenosis,
Severe
or
PS, हाँ।
primary pulmonary hypertension, these are very very lethal for the patient. Yes, valvular is very common. Valvular is very common. Dr. Deepak Modi sir, please.
अगर पेशेंट अगर इमरजेंसी में आ जाए फुल टर्म प्रेगनेंसी विद दिस कार्डियोमायोपैथी विद वेरी लेस इंजेक्शन प्रेशर, व्हाट प्रिकॉशंस वी शुड टेक?
So we should prefer for the cesarean section as compared to the normal delivery, and use general anesthesia, not spinal, and fluid restriction during the procedure also. Don't give any IV fluids. So these precautions we can give, and use diuretics.
जनरल एनेस्थीसिया में जब हम इंट्यूबेट करते हैं तो डेफिनेटली बिकॉज ऑफ पेरिकोस्कोपी देयर इज प्रेशर रिस्पांस ऑन व्हिच इंक्रीजेस द हार्ट रेट। आई थिंक इट शुड बी अवॉइडेड। या तो फिर इंट्यूबेशन शुड बी वेरी क्विक।
This one is really controversial because most of the time, even in rheumatic diseases, we prefer normal deliveries.
हाँ, normal.
Normal deliveries is preferred because in cesarean there will be more blood loss.
वो तो डिसाइडेड है कि जिसमें सिजेरियन होना बिकॉज जो मैंने अभी रिसेंटली केस किया था उसमें तो मेकोनियम पास करता पेशेंट, हालांकि 35 की प्रेगनेंसी, लेकिन मेकोनियम हो रहा तो सिजेरियन करना ही करना। बस दो ऑप्शन है, स्पाइनल या जी।
Spinal या G।
पॉइंट ये है कि हेमोडायनामिक इंस्टेबिलिटी सबसे ज्यादा स्पाइनल एनेस्थीसिया होती है, इसलिए अवॉइड
इसलिए अवॉइड किया जाता है, वो सही बोल रहे हैं। हेमोडायनेमिक स्टेबिलिटी कारण जी है उसको।
जी बचा हाँ।
मेरे ख्याल से ये ही बेटर है, बट इंटरवेंशन शुड वेरी क्विक।
स्टेबिलिटी बेटर है।
जो बीपी डाउन होगा फिर उसको उठाना बहुत मुश्किल होता है।
सही बात।
देना पड़ता है, अगर बेटर तो यही है कि जिए ही नहीं, लेकिन उसमें बस ये है कि इंक्यूबेशन उसका पॉइंट एक और फायदे भी है विद इन 30 सेकंड। बहुत ज्यादा फायदा क्या है इसलिए का, जैसे पेशेंट हार्ट फेलियर में जाएगा ना तो जो मोस्ट इंपॉर्टेंट ट्रीटमेंट है ना अभी भी पल्मोनरी एडिमा का, दिस इज अ 5% वेंटिलेशन।
बिल्कुल बिल्कुल, वो उससे आप
आप उसको 24 घंटा रख भी सकते हैं आईसीयू में और पेशेंट को उसकी पल्मोनरी एडिमा कम करने के बाद फिर बाद में कर दीजिए। अगर आप स्पाइनल दे रखे हैं पल्मोनरी एडिमा में चला गया तो बस में दो फायदे मिले ना इधर। आपका स्पाइनल तो बिल्कुल नहीं देना है, इसलिए कि हेमोडायनामिक इंस्टेबिलिटी बहुत,
हेमोडायनामिक इंस्टेबिलिटी वो इम्पोर्टेंट चीज़ है।
ट्रू।
हाँ।
और पेशेंट ज़्यादातर ये बॉर्डरलाइन प्रेशर्स के होते भी हैं ऐसे भी।
और बीपी देने से बीपी फॉल करती है।
हाँ
बीपी फॉल करती है क्योंकि कार्डियक रिदम कम हो जाएगा।
निकल जाते हैं, सबसे ज़्यादा निकलते हैं, मुझे ये लगा है।
काफी अच्छा डिस्कशन हो गया हम लोग इस टॉपिक पे।
आई थिंक
थैंक यू डॉक्टर गजेंद्र।
थैंक यू।
एक बार मैं फिर से चाहूँगा डॉक्टर गजेंद्र के लिए इनका समय देने के लिए आपको बहुत बहुत धन्यवाद।